So our MEC Minute topic for the month of October is intranasal medications. The topic is based upon an article recently published in the Annals of Emergency Medicine regarding out-of-hospital and emergency department intranasal medication administration. It's a good article. It's attached to the paper version of the MEC Minute. I suggest you read through it because I think it gives you some good background on why we want to do this. Why do we use intranasal medications? Well, intranasal medications are less invasive and in many cases safer than medications being administered intravenously via an IO or intramuscular route. Almost anybody can do it with very minimal training. So even the public can administer medications intranasally, which is why there's a big push for the public to be trained and have available for them intranasal Narcan to treat overdoses. Another thing is sterile technique really doesn't need to be followed because the nose is already a dirty place, and we don't have to worry about keeping the needles clean and maintaining a good aseptic technique while starting an IV or an IO. And the absorption is not really affected by body size or the patient's hydration status. So that if the patient is poorly hydrated or not perfusing well, intramuscular medications are not well absorbed. And if the patient's very large, we don't need to make any big adjustments in medication doses based on their body habitus and ideal body weight. Intranasal medications tend to go directly to the brain, and we'll talk about that in a couple slides, but the medications are rapidly absorbed through the nasal mucosa as well as the olfactory or nasal nerves, that's the nerves that give you a sense of smell, and those nerves will help move the medication directly to the brain. That helps get the brain or the medicine into the brain where it has an effect, but it also helps bypass metabolism of medication by the liver, which often occurs when medications are administered via an IV, IM, or IO route. What are some of the disadvantages? Well, the concentration of the medication or the volume to be delivered may limit the dose, and we can see that as an example with fentanyl. Fentanyl comes at 50 mics per ml. We can only give a couple mLs into the nose at a time, so our total dose of fentanyl may be limited by the volume that we can give at one time. Intranasal medications sometimes may be a little costlier, and that's mostly because of the concentration or the cost of the more concentrated medication, or because of the device used to administer. If the patient's had previous nasal trauma with a lot of bleeding in the nose, or if they've already been given a nasal vasoconstrictor like Afrin or neosynephrine, the medications may not be absorbed as well. So if the nose is full of blood from injury, the medicine's not going to get through the blood to the nasal mucosa for absorption, and if the nasal mucosa has been constricted by a vasoconstrictor, then the medication is just not going to be as well absorbed. Absorption intranasally is also a little less reliable than intravenously, and that's simply because of the mucus and everything else in the nose that may prevent some of the medicine from being absorbed. And some of the medications that are absorbed nasally may be very irritating to the nose. A good example of that is ketamine, which we'll discuss in a couple of minutes. So what makes the medication a good candidate for intranasal administration? Well, it really has to be absorbed easily through the blood-brain barrier via the olfactory nerve and the cribriform plate. The cribriform plate is the bone between the brain and the nose. It is through the cribriform plate that the olfactory nerve passes through. It's the olfactory nerve coming from the brain that gives you your sense of smell. So it has to be able to pass through the membranes in that nerve. To do so, it has to have a neutral pH. It has to be a small molecule. It can't be a large molecule chemical. It's just too big to be absorbed. It has to be lipophilic, or in other words, it has to easily be dissolved in fats, because nerves have fatty membranes, and the blood-brain barrier has a fatty membrane that protects or keeps things getting into the brain. And the molecule or the drug can't be heavily charged, either positively or negatively. Again, it has to be kind of neutral. Other things to consider as what makes a medication a good candidate for intranasal use. You also need to consider, is this medicine something that has to be critically, or is critically important to the safety and health of the patient, and is the drug available in a concentration that's suitable enough for intranasal administration. So if the medication is only available in a dilute form, we may not be able to deliver enough medication via the nose for adequate absorption, or for absorption of enough medication to have any effect on the patient. Just a little anatomy. This is a graph of the nose, and it shows the blood vessels, which are everywhere within the nose. There's a large bed of capillaries within the nose that make absorption better. And if you look at this slide, this is a slide where it compares absorption of medications via the intranasal, oral, or intramuscular route. And if they use the medication morphine, and if you look at it in the first hour, there's a much greater absorption of morphine intranasally than it was given intramuscularly or orally. Another picture, this one showing the olfactory nerve and its area of distribution within the nasal passages. As you can see at the top, the yellow nerve goes through or penetrates that bony area, which is the cribriform plate, and the branches of the nerve then spread out into the nose. It is these branches that are widely distributed with the nose that make absorption directly into the brain more easily, because these nerves allow the medication to be absorbed through the blood-brain barrier, and then it moves into the brain by way of the nerve, where it can be more evenly distributed. Another chart showing absorption rates, and we have three bars. The leftmost is intranasal, the middle is sublingual, and the last one is subcutaneous absorption of a form of morphine, apomorphine, which is a more potent form of morphine. It's also a shorter duration of action medication, but in studies out there shown that intranasal dose of apomorphine results in higher concentrations of apomorphine in the brain than the sublingual or subcutaneous route. So which medications are we going to talk about? We'll talk some about Midazolam, as well as Fentanyl, Naloxone, Ketamine, as well as Precedex or Dexmedetomidine. Precedex is a medicine that's used in the hospital, mostly in the ICUs for sedation of patients who are on ventilators, but it is absorbed intranasally, so we'll discuss it briefly. Midazolam we use, and it's a sedative hypnotic. We use it for sedation, and we use it to terminate seizures. And in the past, we've used it to augment pain control, although we're moving to ketamine for that purpose. Midazolam dose for adults is 5 milligrams intranasally, and then we have our dosing chart that's too large to put or to discuss item by item for seizure patients, and that we discussed that earlier a couple months ago as part of our discussion on Midazolam. Keep in mind that any patient having an active seizure weighing 55 pounds or more, they all get a dose of 10 milligrams of Midazolam intranasally. Intranasal midazolam is rapidly effective, and studies have shown that it has a quicker onset of action if given intranasally immediately on EMS arrival, rather than if EMS were to give it intramuscularly or take the time to get an IV started and then administer the medication. The principal time advantage has to do with rapidity of administration. If patient's having an active seizure, it can take minutes to get an IV started and get the midazolam administered. Midazolam may also be irritating to the nose, but I've not heard many patients complain about irritation. The next medication would be fentanyl. We've used intranasal fentanyl for years. It works very well for pain control, and I would encourage you to think about using it for patients with acute orthopedic injuries, particularly in children. They can get great pain control without the need of going through a painful IV. Fentanyl is a rapidly acting narcotic. It has an intranasal dose of 1.5 micrograms per kilogram. We have a limit of 100 micrograms, and that's to a large extent, at least for intranasal use, based upon how much we can administer at one time and the concentration of medication we have available. So it's essentially 1 milliliter of fentanyl per nostril. It works within 10 minutes and it lasts up to 30 minutes. It has less adverse effects in terms of patient nasal irritation and so on than intranasal ketamine. Intranasal ketamine can be quite irritating to the nose, and it works well with or for patients with acute orthopedic injuries. And I think we could probably use it more for our patients with orthopedic injuries and having significant pain. Naloxone we all use. We all know it works for drug overdoses. Our intranasal dose is 2 milligrams. You can give more if needed. It is easier and faster to administer than IV Narcan. And again, it's mostly because the time it takes to start an IV, particularly in an addict who may have very difficult IV access. Intranasal is as effective as intramuscular, so if you do not have an atomizer but you have the Narcan, you can give it as an IM dose. If an IV is already established, then of course the intravenous dose is preferred. It can induce withdrawal, so I encourage you to give just enough Narcan for respiration to return, not too much to induce withdrawal. I would encourage you also not to give Narcan to somebody if the sole purpose is to make a diagnosis of narcotic overdose. If the patient has a normal spontaneous airway and normal oxygen saturation, I would advocate against giving Narcan or Naloxone for the sole purpose of waking the patient up. Those patients are more likely to have withdrawal, and then the ED providers have to deal with an agitated patient who's in acute narcotic withdrawal. Ketamine we use for combative and agitated patients. We also use it for patients who need augmentation of pain control when fentanyl is not adequate. It is a dissociative anesthetic, meaning it basically disconnects the brain from the body, so the brain is unaware of what's happening. An intranasal dose can be used for pain control or control of agitated behavior. If you're giving it intranasally, the dose is 0.5 to 1 milligram per kilogram. In children, the intranasal dose has been shown to have more side effects than Versed or Midazolam, and that's principally nasal irritation, which just makes a child more upset. We've removed intranasal ketamine from our protocol because of previous provider exposure to body fluids. Providers have given patients doses of intranasal ketamine. It's then blown back in the provider's face, and they have to be evaluated for significant exposure to body fluid. So we've removed intranasal ketamine from the protocol. It can be given IM, it can be given IV. We may reconsider in the future giving it for patients who have intractable pain when fentanyl is not enough, but for now this discussion of intranasal ketamine is more for your information and not because we're going to add it back to the protocol. I added, or Precedex I mentioned earlier. Precedex is a medication that provides sedation without respiratory depression. It can be given intranasally at a dose of 2 to 3 micrograms per kilogram, and it onset is within 20 minutes and it lasts about an hour. Really has not seen its use in the pre-hospital arena, and I have not seen it used in the emergency department. In the emergency department for ventilator patients, we tend to use propofol or a combination of fentanyl and midazolam. It is very expensive, particularly when you compare it to the cost of ketamine and midazolam. So this is added as a item of interest in education, but I don't anticipate that we're going to add Precedex to our outpatient EMS protocol. So in conclusion, use of intranasal medications can result in rapid therapeutic effect with less need of IV access. I think we use it and use it well. Again, I think we could use more intranasal fentanyl for patients with significant orthopedic injuries. And if you would like more information on intranasal medications, I have the website listed here, intranasal.net. It has all sorts of information on intranasal medications.